Clicker here. All right, so we're going to talk a little bit about DEBRICHEM and how this was utilized in a undeveloped situation with limited resources. We have a charity that goes down to Tonga every year now for the last decade, and we treat the complications of diabetic or of diabetes, and one of these is diabetic foot infections. So DevX was kind enough to donate the materials for this. Just to disclose, I'm the Chief Medical Officer for 𝗀𝗏𝗄𝑥 Health, as well as on-site advanced care, and I am currently the president of the American Professional Wound Care Association. So just to give a perspective, diabetic foot ulcers affect about 18.6 million people worldwide and 1.6 million in the US. And about half of these diabetic foot ulcers become infected, and 20% of these result in amputations. Now we have, say in the United States, about say 8 to 13% prevalence of diabetes. In Tonga, over the age of 50, it's closer to 30 to 40%. And over the age of 50, every single person we screened 100% obesity. So obesity is tied heavily into diabetes, and once they get an infection and they get into the hospital, the majority of these folks get an amputation. And so we've gone there for the last 10 years to teach them better wound care techniques, and this was one of the type of tools that really made a big difference when we were using it last summer. So again, I'm just going to give an example of someone that we were treating. This is a 57-year-old female who was poorly controlled diabetes, had developed a wound on her left foot, and her A1, her glycosylated hemoglobin was 13 or higher, actually. She had a wound on her left foot that was being just treated for 38 days, just standard of care, so like debridement, gauze. So in this hospital, all they have is like oil immersion gauze, they have eating gauze, and dry cotton gauze. That's it. So this is an aspect that really is a game changer. So basically what we did on this wound that had been there for over a month, we applied the DEBRICHEM, and this is very simple. We can teach everyone in the clinic, the nurses that are working there, the podiatrists that are working there. Now the podiatrists that are trained, say in the South Pacific, don't debride, like they're not surgeons. They just sort of take care of toenails and calluses and things like that. But this is actually something that they can do. It's within their scope of practice. So you put this on, let it sit for 60 seconds, and then you rinse it off. So you first clean the wound out, you pat it dry, because if you have too much moisture in there, it can react with, get in the way of the chemical reaction. So after 60 seconds, you get this caramelized look. Now when I first saw this and working with it, I'm like, oh my goodness, what did I do to this wound, right? But this actually creates this desiccated layer that protects the wound bed. And one of the significant components of this product is, per the instructions, against instructions, she wanted to go to church over the weekend, so she put on a very tight dress shoe. And that created a major pressure injury within this wound. And if it really wasn't for the DEBRICHEM, she probably would have gotten infected with this wound, because she did not come in for 3 to 4 days. But the fact that we had eliminated the majority of the bioburden in this wound really protected it. So she came in, and at this point, we just debrided all this top layer off. And we gave her an offloading boot, which we had a couple extras with us. And you can see after we debrided it, she had the joint capsule exposed there. So she really was at risk for worsening amputation. We cultured this, we started her on an antibiotic, but then this is the first time that we actually published, or this has been published, where we used a skin substitute. And so this is a ovine foregut matrix that was placed over this, and it was placed every week after we had treated with the DEBRICHEM. And over time, so basically 90 days later, she finally had gotten to the point where she was healing. She covered up the area over her joint capsule. This is one of the reasons why it took so long, is we had to cover over a sort of a synovial space. And then by the end of this, by the 11th, so remember we started this in July. So by the beginning of November, she finally had completely resolved. So we were actually managing her from remotely with the nurses on the island. And they were very good at reaching out and asking for help whenever something went forward or that was wrong. But this is an example where pairing the chemical debridement with this desiccating agent, and then which would be part of the wound bed preparation, and then with the complication or stalling of the wound, we closed it with a xenograft. So this is no one has really done this before, but this was actually done in a very remote area with limited resources. So I think that's about it.